As we were already discussing the neurological assessment of a patient and how do we carry about and go in an organized manner just to have the definitive diagnosis and surely get to know the basic problem and obviously have the proper management of the patient is very interesting, and we went through the initial steps in the previous lecture, and this lecture is basically a continuation of the previous lecture. So we already laid the foundation that whenever we have a patient of any sort of a neurological problem, for instance, the patient is suffering from some sort of a paresis, and he or she comes up to you, you're going to start off your diagnosis and move on by starting on with the history taking in a proper manner. So whatever the region is that you're focusing on, whether it is the mini mental state examination, we started off with this criteria of the mini mental state examination just to assess the orientation of the individual and just to get to know that whether he or she is well oriented in time, space, and person. Is he or she cautious? Does he or she have the insight towards their own problems? Can they perform simple arithmetic calculations? And do they still possess the abstract thinking that a normal individual possesses or not? So for that stake, we had an initial mini mental state examination that was carried out. There was a form which basically had a total of 30 points, and the patient had to score at least a total of more than 25 to get to a normal state of an individual. So obviously, all of these scorings would depend upon the age of the individual and obviously the educational status of the individual. Keeping in view all of these criteria, so we'll put forth the questions of the mental state examinations in these individuals, and then obviously you're going to focus on the history taking as well. So over here in this particular lecture, we are moving on with another integral part of the neuro assessment, that is the cranial nerve examination. Now this is again a very interesting topic, and as at undergrad level you should remember the criteria for examining the cranial nerve examination, as well as you should get to know the names of the cranial nerves. Now, as the name is suggesting, the cranial nerves are basically directly coming out of the brainstem and the brain. So that is why they are named accordingly. And we have 12 pairs of cranial nerves that we'll be studying over here. But before that, we went on and we go into the explanation of the examination of the cranial nerves. You must know that we should have a strong foundation of the history, whatever the case is. Even if you're suspecting that this person is suffering from some sort of a cranial nerve disorder, there are a range of multiple cranial nerve disorders that you would come across as a clinician, ranging from Bell's palsy, Meniere's disease. Then we have the different neuralgias. For instance, we have the trigeminal neuralgias. So we'd be studying, as I'll be mentioning the examination of these cranial nerves one by one. I'll be also mentioning the different disorders that are related to these cranial nerves specifically. But whatever the case is, to get to know to the definitive diagnosis, one should take the history in detail. For instance, usually just consider that you get a patient in your outpatient department who is suffering from tinnitus, that is the ringing of the ringing sensation in the air, as well as he or she is also suffering from imbalance and coordination. So these are the symptoms that he or she comes up to you with, and you have this case. Now you don't have a definitive diagnosis just right away. You have a differential diagnosis that either this person can be suffering from Meniere's disease or it can be even an acoustic neuroma. Whatever the case it is, basically it is affecting the eighth cranial nerve. The eighth cranial nerve, which is responsible for the hearing, which is responsible for the balancing, that is involved. So you would take the history in detail, and that is going to shed light upon whether which one of these diagnoses is correct in this particular patient. You would also take the history from the patient's relatives and close friends. This is basically known as the corroborative history, which is very important when you have these patients of neurological pathologies at your hand, and you're suspecting that this person might be suffering from either the cranial nerve disease or even the peripheral nervous system is involved, or whatever the case is. But still, if you have basically customized that this person is suffering from some sort of a neurological disorder, a detailed history including the history of presenting complaints, that would basically include the time of the onset and as well as the temporal course of the disease, that would be discussed in detail while you're documenting the history of presenting illness in this particular patient. As well as you would take the family history, the drug history, past medical and surgical histories are very important over here, because sometimes even the recent surgeries can lead to neurological trauma, and usually the patient presents post-surgically with some sort of neurological complication. So having to get to know the patient in detail is very important over here. And you would also write in detail about any sort of drug history that the patient might be on. Either they are the prescribed drugs, or either it can be the use of any illicit drugs that the patient might be taking or might be exposed to. Even the toxins in the environment are again very important. If he has some sort of an occupational hazard, that has even to be highlighted while you're taking the history from the patient, or while you're taking the corroborative history from the relatives as well as the friends. So over here, when you have these cranial nerves at your hand, one should first of all remember that we have a group of 12 cranial nerves at our hand. We have the optic nerve, the olfactory, and the oculomotor initially. So the first cranial nerve is basically the olfactory nerve, and then we move on to the optic, which is the second cranial nerve. Mentioning over here, we have the third cranial nerve, which is known as the oculomotor nerve, and then we move on to the fourth cranial nerve, which is the trochlear nerve. Moving on, we have the fifth cranial nerve, which is known as the trigeminal nerve. The sixth cranial nerve is the abducens. We have seventh cranial nerve as the facial nerve. Vestibulocochlear is the eighth cranial nerve. Ninth, we have the glossopharyngeal. We have the 10th cranial nerve as the vagus. We have the hypoglossal and the accessory cranial nerves over here. So these are basically the group of 12 cranial nerves that we have. All of them are usually in pairs, as you can even see in this diagrammatic representation. So one of the features that is related to all of these cranial nerves, that they appear or they occur in pairs, and as well as you have to focus on the fact that all of these cranial nerves are coming directly out of the brain, or particularly they are coming out of the brain stem. Majorly, most of the cranial nerves are basically exiting the brain through the brain stem. So this is the basic thing that we have to remember when we are studying the cranial nerves. A very interesting way to remember the names of the cranial nerves is an interesting mnemonic that would basically help you out in remembering the names of the cranial nerves, and that too in a correct order, because it's again very important to remember all of these names in a correct order. Now over here, as you can see, we have this mnemonic, which is basically a sentence. On occasion, our trusty truck acts funny. Very good vehicle anyhow. So you can just focus on the fact that the very first letters are basically having the reference to the cranial nerves over here. you can just appreciate over here that there are three O's in a row, which are basically standing for the olfactory, first of all. Then we have the optic and the third cranial nerve, which is the oculomotor cranial nerve over here. Then we have the fourth and the fifth cranial nerve. The fourth cranial nerve is the trochlear. Then we have the trigeminal over here. Then we have the abducens, facial, vestibulocochlear, glossopharyngeal, vagus, accessory, and hypoglossal. So this mnemonic would basically help you out in remembering these cranial nerves in an order. Again, it's very important to remember them in an order because it's sometimes the Roman numerals that are used when you're documenting any disorder on a particular platform. You would be using, for instance, you'd be using the third cranial nerve disorder, or you can be using the second cranial nerve, and then you can have that a coherence in your mind that basically we are talking about the oculomotor nerve, or it's the trochlear nerve that we want to talk about. If we look into the functions of these cranial nerves over here, you would just appreciate over here that the olfactory nerve is basically responsible for the sense of smell. Then we have the optic nerve, which is basically having the indentation in the eyeball. It's carrying out the signals to the cerebral cortex, to the visual cortex for the final imaging in our visual system. So it's really playing a role in the visual system. And then we have the third, fourth, and the sixth cranial nerves. We usually talk about the third, fourth, and the sixth cranial nerves, that is the oculomotor, trochlear, and abducens, in a group. Why do we do that? Because their function is the same. They are responsible for the extraocular movements of the eye. So that is how, even when we are clinically evaluating a patient, we would be checking the third, fourth, and the sixth cranial nerve collectively by any methods, and that is basically by checking out the extraocular movements, or either the patient is suffering from some sort of a paresis in any one of the cardinal directions or not, and that is basically going to point out towards the fact. Then, as you can even appreciate over here, we have the trigeminal nerve, and that is, we have these three major branches of the trigeminal nerve. We have the ophthalmicus, then we have the zygomatic, and then we have the mandibular branch. So these are the three major branches of the trigeminal nerve, and it's usually supplying the skin of the face. So this is the usual function of the trigeminal nerve. Moving on, we have the vestibulocochlear nerve, that is the eighth cranial nerve. The basic function of the vestibulocochlear nerve, as even the name is suggesting, it's supplying the vestibule as well as the cochlea. So it's basically responsible for performance of the balancing, as well as it helps out in the hearing. So if we have any problem that is relating to the vestibulocochlear nerve, the hearing is going to be impaired, as well as the balancing and coordination is also going to be impaired in this particular individual. Then we have the glossopharyngeal and the hypoglossal muscles are basically supplying the muscles of the tongue, and that is the way we check the functionality of these cranial nerves as well. The accessory cranial nerve is supplying the muscles of the neck mainly. We have the muscle of sternocleidomastoid as well as the trapezius muscle, which is being supplied by the accessory cranial nerve over here. Moving on, we have the vagus nerve, and that has its parasympathetics as well over here. So this is the overall functionality of the cranial nerves. Now there is a clear distinction between the spinal nerves, we have almost 31 pairs of spinal nerves that are coming out of the vertebral column through the dorsal root ganglion. So they have their motor component as well as they have their sensory component that is involved in a particular spinal nerve when we talk about it. Again, they ascend and they descend through the spinal cord, and then they reach their final destinations inside the cerebral cortex for the further evaluation of the messages and the signals. Then obviously the signals are transmitted through the descending tracts for the motor reflexes to be carried out. Whenever we are neurologically assessing a patient, one should basically know the particular way and the particular organization. How do we start off with the neuro assessment? Basic function or the basic way in which usually as a clinician you would carry out this neurological examination is, first of all, the mental state examination that you would quickly carry out, and then would be the second step of the cranial nerve examination. Then we have the motor system to be evaluated, the reflexes are evaluated along with it, and we move on to the evaluation of the sensory system after that. Moving on, we'll be checking out for the coordination, and as well as when the patient even walks inside your clinic, you're going to look for any imbalances by observing the gait of the patient in a particular manner. So all of this is basically how you master the act of neurological assessment. Whatever way or whatever numbering that you follow, you should carry that out and practice that out so that you master the activity of neurological assessment in these patients. The bare minimum that you would start off with, even in any other neurological examination, or even before you start off with the particular cranial nerves to be started off, you're going to look for the fundi. How are you going to check for any fundoscopic findings? Obviously, you're going to use an ophthalmoscope for that and look for the fundoscopic findings. A normal pallor of the optic disc, the retinal vasculature, all of these are going to be assessed when you are looking at the retina of the individual and assessing any maculopathies or any optic neuropathies. If there is a pallor in the disc, if there is a papilledema that is noted down at the level of the optic nerve, you're going to write down all of these findings on your documentation, of course. Moving on, we're going to check the visual fields of the individual. Again, it's very important how you're going to check. It's basically a subjective method of checking the visual fields in the individual. Basically, you ask the patient to stand at a distance of almost 2 to 3 feet, and then you start off by your index finger, which is moving on cardinally. Basically, you're going to start off with the peripheries and you're going to move down the fingers and note if there is any sort of a visual defect noted down in the patient subjectively through your own assessment as well being carried out. So this is one of the methods. This is a manual method for checking out the visual fields, and we have other automated methods also by which the visual fields can be checked for, and we got to know the physiological blind spot that is present in the visual field. And that is nothing pathological. It's basically a physiological phenomena that is observed in these individuals. Then the pupil size, of course, you're going to look for the light reflexes, the normal pupil size, and also look for any pupillary dilatation or mydriasis if it is noted down in the individual. The reactivity, reflex activity, after you throw light on the pupils, the constriction of the pupil is noted down, and that is basically going to show the reactivity of the individual. Asking the patient to look into the 6 cardinal directions is how you monitor the extraocular movements, and this is one way of also checking 3 most important cranial nerves, that is the third, fourth, and the sixth cranial nerves. And then obviously a normal generalized facial movements, ask the patient to chew, ask the patient to blow, and that is basically going to show if the patient has some sort of a weakness that is observed on a particular part of a face or not. So that is basically how you're going to look for any positive signs of any signs of paresis, as you note down the facial movements, the extraocular movements, and you look for findings on the fundoscopy, and the ocular examination is very integral part of the neurological examination over here. Starting off with the examination of the first cranial nerve. Now, this is basically the olfactory nerve, which is responsible for the sensations of smell. So whenever you're going to check for any abnormality in the sensations of smell, obviously you're going to ask the patient to close his or her eyes and make him basically identify strong smells, such as you can offer coffee beans or even spirit swabs can be offered for the identification. So this is quite easy how you perform this kind of examination of the olfactory nerve. Now, what are the particular pathologies that are affecting the olfactory nerve? There are certain conditions in which the anterior cranial fossa is involved. It can be any sort of traumatic conditions, it can be the neoplastic conditions, as well as the some sort of infectious states that can even arise and affect the olfactory nerves, as well as it can be the drug effects that can basically desensitize the olfactory, the first cranial nerve, that is the olfactory nerve. So these are some of the situations in which the sense of smell can be altered, and it is basically going to affect this functionality of the first cranial nerve. Now, there are some situations, for instance, in which the patient is going to misdiagnose or misidentify the sense of smell of particular agents, and then obviously you can recheck by giving or offering any of the other agents that are available. So the subjective testing is sometimes also quite important as a clinician yourself. When you're carrying out this test in your own offices, you can have a subjective view of the smells as well. If it is an alteration of the first cranial nerve functionality, or is it just the subjectivity of the patient that is affecting the results of the test? Moving on, we have the functionality of the second cranial nerve, that is majorly the optic nerve. Now, any disorders that are relating to the optic nerve, or that are severing the optic nerve, or even affecting the functionality of the optic nerve, may it be the infectious states, the meningitis, the papilledema, a lot of ocular states. For instance, glaucomatous conditions can even pressurize the optic nerve and can result in damage that is relating to the optic nerve. So any of these conditions which are basically manifesting as the optic nerve damage can affect the final visual impairment in the individual. Even if they are left untreated, it can result in complete loss of vision in the individual. So it's very important to check for the normal functioning of the optic nerve. And how do you go about and assess the optic nerve? First of all, the Snellen's chart. So we use the Snellen's chart for performing the visual acuity in the individual. So almost a distance of 6 meters, you ask the patient to read out the letters that are present on the Snellen's chart, and this is a rough way just to get to diagnose any sort of disturbances in the visual acuity that can be noted down in the individual. Then visual fields, of course, we can have the manual methods for testing out the visual fields, as well as A lot of automated techniques have been devised for testing out the visual fields. Apart from the normal presence of the blind spots, that is a physiological phenomena that you can observe, you're going to note down whether the patient is suffering from some sort of a peripheral vision or either it is a tunnel vision. Whenever we use the word or describe that the patient is suffering from a tunnel vision, it means that he has lost the peripheral vision. Again, there are particular diseases in which the patients are suffering from this kind of visual field effects, and it can be even the floaters or even the permanent scotomas can be identified at this level. Whatever the patient is complaining of and whatever you diagnose in a particular patient, you're going to note that down and document in a peculiar manner. Again, the optic fundus examination by the use of retinoscopy or ophthalmoscopy after you have applied the dilators and performed the mydriasis, and now you're going to look for any findings on the fundus of the individual. It can be any sort of abnormal tortuosities that you observe on the fundus of the individuals, the AV nicks, the arteriovenous nicking or fistulas, the hemorrhages, cotton wool spot appearances. All of these are basically giving you out the diagnosis towards different diseases. So you're going to note down all of the features over here, and even the special features for the optic disc. The normal pallor has to be distinguished from the features of papil edema over here. So that is going to, papil edema is basically going to be an edematous condition that is occurring at the entrance or the severance of the optic nerve, and that is going to affect the functionality and the imaging that is carried out by the optic nerve over here. Then obviously we have the retinal vessels that are again observed and catered for when we are carrying out the ophthalmoscopy or retinoscopy in these individuals. The third, fourth, and the sixth cranial nerves are usually checked collectively. Now, it's basically because the major function that they are performing is the extraocular movements. The third cranial nerve is supplying the superior, the inferior recti muscles. Just for the exception, you have to remember that the superior oblique is supplied by the fourth cranial nerve and the lateral rectus is supplied by the sixth cranial nerve. Apart from that, all of the recti muscles and the inferior oblique muscle is also collectively supplied by the oculomotor nerve. So this is the general way how you remember the innervation to the extraocular muscles over here. It's again very easy. You have to remember the superior oblique supplying the superior oblique that is supplied by the fourth cranial nerve and the lateral rectus which is supplied by the sixth cranial nerve. And apart from that, we have the oculomotor nerve supplying the rest of the extraocular muscles. So to check the functionality of all of these cranial nerves, we first of all look for the general size and the shape of the pupils, and then obviously you're going to see the pupillary light reflex that is demonstrated over here. The reaction to light as well as the accommodation is also checked. So how do you check the accommodation? You perform the simple finger nose test that is performed for these patients, and the normal squinting phenomena when it is observed in patients who are converging to focus on the finger of the physician, that is basically a normal phenomena which is showing that normal accommodation reflexes in the patient. So how do you basically go about and check for the normal cardinal signs over here? You ask the patient to look into the directions of upright, then obviously the complete right of the individual, and then you also ask them to look in a diagonal direction, that is the down right. Then we have the up left, left, and finally we have the down left direction for the patient. So these are the 6 cardinal directions in which you ask the patient to look for you. The distance between the physician and the patient is almost 2 feet. Obviously, that is the normal generalized distance in which you perform this test for the patient. And obviously, it is again going to show any abnormality or any dysfunction of the oculomotor, trochlear, and the abducens nerve, which are basically the third, fourth, and the sixth cranial nerves. So if any paresis is noted down, or even if you can even look for the associated features. For example, if any nystagmus is noted down in the individual while he's looking in a particular direction, that is also documented while you're noting down the features for the particular patient. Then we have the trigeminal nerve, that is the fifth cranial nerve, and the sensory examination or the sensory component of the trigeminal nerve is a very integral part of the cranial nerve examinations over here. So this is a diagrammatic representation that basically shows the different areas of the trigeminal sensory nerve supply. This green area is basically signifying the ophthalmicus division of the trigeminal nerve. We have the pinkish area, which is basically the maxillary division, and then we have the mandibular division of the trigeminal nerve. So these are the three major sensory divisions or sensory areas that are supplied by the trigeminal nerve. So whenever you check for the sensations by a cotton wool that is placed on these areas, and the patient is going to have the subjective feeling of that cotton wool in these particular areas, or even if he or she doesn't feel for that sensations, you're going to document the absence of sensations in the particular division of the trigeminal area that is being supplied over there. So this is the mandibular zone, this is the maxillary, and then we have the ophthalmic zone that can be checked for sensations over here. If the normal touch sensations cannot be checked for, we can also go about and check for the painful stimuli that can be applied in these modalities. Then obviously we have the trigeminal modalities. Other than the sensory examination, you're going to check for the corneal reflex by placing a swab, and the blinking should be a normal response accentuated in the individuals. Then we have a jaw clench that we usually make the patient to perform. It's basically for checking the functionality of the masseter muscle, which is a very important muscle attached to the mandible. So you ask the patient to clench the jaw, and if he or she is not able to do so, that is basically going to detect the paresis or the paralysis of the masseter muscle in any sense. Moving on to the facial nerve, this is the seventh cranial nerve that we're going to talk about, and how do we go about and check for the abnormalities of the seventh cranial nerve. The facial asymmetry is checked at rest. You ask the patient to elevate the eyebrows, forehead wrinkling is done. Then you ask him to close his or her eyes. Ask the patient to smile, and then obviously cheek puff is being performed. That is basically you asked or instruct the patient to blow out the cheeks, and if he or she is not able to perform this function, that means if it is on an affected area on only it is an asymmetrical dysfunctionality noted down, it's usually the case of Bell's palsy. Bell's palsy is a very common pathology that is sometimes associated with, particularly associated with this cranial nerve, that is the seventh cranial nerve. It's usually the viral infection which is caused by the herpes simplex type 1, which is affecting, when we are talking about the Bell's palsy, it's a lower motor neuron palsy. And what are the particular features? There would be this drooping of the eyelid on the affected side. Then obviously there would be the angle of the mouth would also be drawn downwards, and there would be the paresis of the affected part of the face. The half part of the face is affected. When we usually encounter these patients of Bell's palsy, they perform or they respond very well whenever you give out the treatment of steroids that is prescribed for these patients of Bell's palsy if it is diagnosed in a particular case. While you're checking out for the facial nerve, you're going to look for the differences in the lower versus the upper facial muscles. The weakness of the lower two-thirds of the face with preservation of the upper third, it's usually an upper motor neuron lesion. And the weakness of an entire side, that is the case that I've already discussed, that is the Bell's palsy, it's usually a lower motor neuron lesion. So usually check for whether it is one side, it is just subjected to one side, or if it's just two-thirds of the face that is preserved, that is usually the upper third is preserved, it's an upper motor neuron lesion. So distinguishing between the upper motor neuron lesions and the lower motor neuron lesions is again a very important and integral part of the neurological examination whenever it is carried out in these patients. Moving on, we have the vestibulocochlear nerve, that is basically the 8th cranial nerve. You check out by the finger rub and a whispered voice in both of the ears. You check individually for both of the ears. One of the tests that is performed is the Raynaud's test. It's basically when you use a tuning fork that is almost 512 hertz tuning fork that is used, and you place the tuning fork and ask the patient if he or she can hear a voice. That is basically a normal conduction test that is performed in these cases when you are performing or when you are subjecting towards the Raynaud's test. Then we have the same tuning fork for the Weber's test. You basically check for the mastoid ear cell conductions and a normal conduction, and all of these tests are basically performed for checking out the functionality of the vestibulocochlear nerve over here. As the name is indicated, we have two components to this nerve. One is supplying, and one is responsible basically for the balancing and coordination in an individual, and obviously the cochlear nerve is responsible for the hearing. So if any one of the integral part is affected, that is basically going to affect the balancing as well as the hearing impairment is also seen in these patients in which you look for these signs of vestibulocochlear impairment. So it's again very important you check for the history in these individuals. We have the most notorious diseases that are affecting this 8th cranial nerve. Mainly we have the Meniere's disease, which is basically the ringing sensation, as well as there is loss of balance in the individuals who are suffering from the Meniere's disease. On the other hand, we have acoustic neuromas, which is basically a non-cancerous growth on the 8th cranial nerve, and it is again going to present with the tinnitus, vertigo, headache, nausea and vomiting, and obviously imbalance in the patient who are suffering from the pathologies that are affecting the vestibulocochlear nerve. So then we're going to start checking for the pathologies of the 9th and the 10th cranial nerve, that is the glossopharyngeal and the vagus nerve primarily. We're going to ask the patient to position and look for the symmetry of the palate as well as the uvula at rest, and it can be done only after you ask the patient to protrude the tongue. So you also ask the patient to basically phonate the word ah, and a gag reflex is also checked over here, and all of these are basically going to point out towards the pathologies of the glossopharyngeal as well as the vagus nerve over here. Moving on, we have the 11th cranial nerve. Primarily over here, we have the spinal accessory nerve. Now, this accessory nerve is responsible for the supply towards the muscles of the neck. So we have the sternocleidomastoid as well as the trapezius muscle over here, and to look for the functionality of this nerve, you can indirectly look for the functionality of these muscles. you check for the shoulder shrug, and you also ask the patient for head rotation towards each side, but that is also against resistance. It's not a normal rotation towards any one of the sides. It's basically against resistance that you're going to check for the functionality of the sternocleidomastoid on the same side. So this is basically how you go about and check for the trapezius muscle as well as for the sternocleidomastoid muscle over here. Then finally, we have the 12th cranial nerve, that is the hypoglossal nerve. And how do you basically check for it? You look for the symmetry of the tongue. You ask the patient to protrude the tongue, and any asymmetry and any deviation, if it is noted down, that is basically going to relate to the pathologies of the 12th cranial nerve, that is the hypoglossal nerve, the major nerve supplying the muscles of the tongue. So these are the normal clinical tests that we perform for the functionality of the major 12 pairs of the cranial nerves coming out of the brainstem, and how can they basically affect the normal functionality in the individual. One thing that we have to remember is all of these cranial nerves have a sensory component as well as a motor component, and some of them are a combination of sensory and motor. So here you're going to check for the sensation as well as the motor capacity of these nerves whenever you're going to perform the clinical tests, and look for the for any pathologies relating to all of these cranial nerves. It can basically be the infectious states, the neoplastic conditions, the surgical trauma, or even any trauma that is affecting the functionality and the normal functioning of these cranial nerves in the individual. So that is the end to this lecture. Thank you for watching sqadia.com.